Hello everyone, I'm Henry, and thank you for joining me. I want to thank the ASA for giving me the opportunity to speak. It is quite the honor. Today I'm going to be talking about neonatal neurosonography, and it's going to be broken down into two sections. The first section is just going to be the basics, technique, anatomy, and then the second video will be on pathology. So lecture objectives, like I said already, anatomy. We're going to go into a detailed overview of the neuroanatomy, techniques, probe selection, scanning approaches, and then in the second video, pathology. All right, so probe choice. Now, when you're doing neonatal neurosonography, you want to use a high megahertz transducer to get good resolution. And we have small probes that are just for that, like the sector, that goes up to 10 megahertz. My favorite are these little curved ones, the microconvex array transducers. They're usually from 3 to 10 megahertz. They take very, very good images, much better than the sector probes, in my opinion. And then finally, linear probes to get those really nice high resolution images. Here you can see the difference from a sector probe in a parasagittal view and the linear. You can see so much more detail with the linear. Obviously, the older the baby gets, the bigger the baby's brain gets or their head gets, and the smaller their fontanelles get, using a linear is less feasible. All right, so indications for neonatal cranial ultrasound. Prematurity is probably the number one reason to do these exams. Any premature infant less than 32 weeks or less than 1,500 grams is at an increased risk for hemorrhage. Low APGAR scores, any neurological change upon admission or during admission, cranial dysmorphisms, so macrocephaly, microcephaly, cranial synostosis, and follow-up for known hemorrhages or other pathology. Key sonographic features that you want to pay attention to and learn are the interhemispheric fissure, the SYLVIAN fissures, also known as the lateral sulcus, CAVUM septa pellucidum, corpus callosum, basal ganglia, especially the caudothalamic region, the ventricular system, so the ventricles, and the cerebellum. So here is a diagram I made of the lobes. Pretty simple. Yellow is frontal, green is a parietal lobe, purple is a temporal lobe, and orange is the occipital lobe. Each lobe has its corresponding bone. And then you have the cerebellum and brainstem. So let's begin with the interhemispheric fissure. The interhemispheric fissure is an invagination or a deep groove of the dura mater. And the tentorium is also an invagination of the dura mater that separates the cerebrum to the cerebellum. The interhemispheric fissure is also called falx cerebri, and it separates both hemispheres of the brain. Once it goes down, it eventually meets up with the corpus callosum. All right. SYLVIAN fissures are lateral grooves. They're deep lateral grooves around the temporal region. They separate the frontal occipital lobes to the temporal lobes. They look like sideways Ys, I always tell my students, and the insula is buried deep to it. Let's go back real quick. So here you have the temporal lobes. Cavum septum pellucidum, or cavum septi pellucidi, is a midline cystic structure in between the anterior horns of the lateral ventricles. It is a fetal neurodevelopmental marker. So when you're doing fetal scans, it's one of the things we look for. And it's present in normal brains. People who do fetal scans are very well familiar with this structure. Absence of this structure has been associated with central nervous system anomalies like septo-optic dysplasia, hollow prosencephaly, and corpus callosum agenesis. It usually fuses by 6 months. It is present in a lot of newborn infants. We see it quite a lot. It's a normal structure. And it persists in 15% of adults. It is not that it really obliterates, it's that just as you grow up and your brain gets bigger, the lateral, all the structures get kind of closer together and you can't really make it out like you can in fetuses and in neonates. So here we have a sagittal and a coronal view, and that's the cavum septum pellucidum right there, and in coronal. And then we have a gross pathology example in coronal, also showing the anterior horns of the lateral ventricles and the cavum septum pellucidum. So cavum vergi is one that not everyone is familiar with. If you do a lot of brain ultrasounds, you will be familiar with this, but it's a continuation of the CSP. It's usually posterior and beneath the splenium and body of the corpus callosum. Here you can see a CSP and cavum vergi. It is present in 30% in infants and present in less than 1% of adults. Here you can see the normal CSP without the cavum vergi in this patient. Then we have the CAVUM VELLI interpositi, or CAVUM vellum interpositum. It is a supratentorial cystic structure. It is antero-inferior to the splenium of the corpus callosum, so it's more inferior, more posterior than the cavum vergi. There's no associated congenital anomalies. And here is its structure right here. Anytime you do see this, it's good to put color Doppler because this is an area where you can have arachnoid cysts quite commonly. And also a vein of Galen aneurysm could be present in this portion here. So you can put color Doppler to rule that out. All right, so the corpus callosum, very important structure. It's a horizontal bundle of nerve fibers that connects both hemispheres of the brain. It is the largest white matter structure, consists of over 200 million axons. Its components are the rostrum, the genu, the body, and the splenium, from anterior to posterior. It is important for eye movement, cognition, and tactile localization, and it is reportedly larger in females. Maybe that's why women are more smarter. So here you have a coronal view of the corpus callosum. And here's a sagittal zoomed up view. There you can see the rostrum is like a little beak portion right there. And then you got the genu, which was right here. The whole body, and then the splenium. Splenium is towards the back. It's posterior. I usually remind the students that when you're trying to scan the spleen, sometimes you got to scan more posterior to get a good spleen image. And splenium is posterior to the back. All right, so the germinal matrix, very important structure that is highly vascularized, thin membraned, and it's important for us because this is where the germinal matrix hemorrhages begin, so the bleeds. It is located in the subependymal region of the caudothalamic groove, so where the caudate nucleus and the thalamus meet. It is a source for neuronal precursors that constitute brain parenchyma. What that means is primitive nerve cells begin here and then they migrate outwards. And here is that caudothalamic groove. So parasagittal, you got the caudate nucleus here, the thalamus, and in this portion right here, that's where the caudothalamic groove is, germinal matrix is, and if you do have a bleed, that's where it's going to be. So it'll be a germinal matrix hemorrhage or a subependymal hemorrhage, which subependymal meaning under the lining of the ventricle. Here is with a diagram. And it's important to note that the echogenicity of the choroid plexus is going to be very similar to grade 1 bleeds. But the location is important. The choroid plexus usually begins about 1/3 to halfway of the thalamus. And then it tapers there. So if you have this there, a lot of people when they first start scanning, they confuse that with blood. That's not blood. That's the choroid plexus. So the location here, if you have a little hump there, that's echogenic. Then nothing, then the choroid plexus, that part is the blood. All right, so now let's go to the ventricular system. So the ventricles are just a series of chambers inside the brain that are filled with cerebrospinal fluid. They contain the choroid plexus as well, which create that cerebrospinal fluid. There's the paired lateral ventricles, the third ventricle, and the fourth ventricle. So here's a diagram of the ventricular system in a parasagittal view and a coronal view. So here you got the lateral ventricles, which would be anterior horn, occipital horn, temporal horn. And then you have the third ventricle. This little structure is where the thalamic adhesion or massa intermedia is. So pretty much the midline of the thalamus. And then you have several foramen and channels that connect the ventricles, like the foramen of Monroe and the aqueduct of Sylvius, or the cerebral aqueduct that goes down into the fourth ventricle. And here's a diagram of a parasagittal view of the lateral ventricle. So again, anterior horn, posterior horn or occipital horn, temporal horn, and the choroid plexus. And here's a coronal view showing the anterior horns of the lateral ventricles, the foramen of Monroe on each side, and the third ventricles. The larger the baby is, the less you're going to be able to see these structures. So here we have the third ventricle in midline sagittal. So let's go back. In coronal, the third ventricle is like a slit. And then in sagittal, it looks broader. Obviously, in more premature infants, you're going to see it easier. In larger kids, you're not going to see it as well. So is this structure right here? That's the third ventricle. This is the massa intermedia, or the thalamic adhesion, which would go right there. And then from here, you have the cerebral aqueduct, or the aqueduct of Sylvius, which goes into the fourth ventricle, then the posterior fossa, and then into the spinal cord. So that's aqueductus sylvius, and the fourth ventricle, which is always triangular shaped and anterior to the cerebellum, midline of the cerebellum, which would be the vermis. So extra-axial spaces are important because you can have collections there from benign enlargement of the arachnoid spaces, which is common and common cause of macrocephaly, up to and including subdural hemorrhages or epidural hemorrhages. And here you can see the layers. So this is the dermis, this is the skin. Then you have the dura mater, then the arachnoid space, and the pia mater around the brain. So these three layers are the meninges. And I use DAP as a mnemonic to remember: DAP, dura, arachnoid, pia. I'll go over some more detailed images of these spaces later on. So the choroid plexus, very important. It is a network of epithelial cells, capillaries, and connective tissue that creates the cerebrospinal fluid. It also filters wastes. It is located in the lateral ventricles, as you can see here. It is also located in the third ventricle, on the roof of the third ventricle, and the fourth ventricle, and they're hyperechoic. So now let's go into scanning windows. So the standard windows that we scan is the most important is anterior fontanelle. So here we have a fetal or neonatal skull, and you can see the parietal bones, the frontal bones, the parietal bones, and then what would become the sutures and the anterior fontanelle. So if you put the transducer right there and just right there and rock it anterior to posterior, you can get all the coronal images. You want the notch or the indicator of the transducer to be on the patient's right side. And then when you're sagittal, you want the notch facing anterior, and then same rocking motion side to side, you can get your sagittal and parasagittal views. So we begin our exam with 6 coronal views from anterior to posterior. As you can see, doing that fanning motion. Oftentimes, you don't even have to move the transducer. Just tilting it and fanning like that, you can get all the images you need. Obviously, also pivoting and rotating to get your image as straight as possible, because if the baby's moving, or if you're angled or you're off axis, you're going to have a very tilted image, which is not, it's not as aesthetically pleasing, and you might miss something as well. So all the way anterior is where we begin, and you can see the frontal horns, the periventricular white matter, interhemispheric fissure, the cranium, which kind of looks like a bird swooping down. That's the way they trained me, or taught me. And then the orbits. But I like to prefer to know the real anatomy. So again, interhemispheric fissure and the frontal lobes. And there you can see that bird swooping down. I guess it's like a dove or something. I don't know. All right. So more posteriorly, you start to begin to get the little temporal horns, the cavum, septum, pellucidum. You see how this is a term baby and how tiny the lateral ventricles are. Interhemispheric fissure and corpus callosum. So corpus callosum looks like a blue macaroni. Interhemispheric fissure, cavum, septum, pellucidum, the lateral ventricles, frontal lobes, and the temporal lobes. And one of the Sylvian fissures seen relatively clearly. This is with the sector probe. Like I said before, with the micro curved array probe, the images are just fantastic. This one's with a linear, see it much prettier. So again, Sylvian fissures. This is just slightly more posterior back. You got the suprasellar cistern right here, thalamus, caudate nucleus. So bleeds would start around here in coronal, temporal lobes, midbrain, cingulate sulcus, and then the Sylvian fissures, which I already said. And then that blue macaroni corpus callosum. Slightly posterior back. Again, you have the lateral ventricles. Earlier I mentioned that the third ventricle has choroid plexus and the roof of the third ventricle, and you can see that pretty clearly there. So third ventricle, lateral ventricles, corpus callosum, very clear with a 9 megahertz transducer. Foramen of Monroe on both sides. More angling, more posterior. Now you start to get the tentorium. So you got cerebellum, tentorium, lateral ventricles with a little bit of choroid plexus in it. And this is important to note because when you first start scanning these, you might go here, and if you're inexperienced, you'll see that, and you're like, oh no, is that a bleed? But you got to know your position. This is more posterior. The caudothalamic groove is anterior to this. And the bleeds usually be a little bit bigger than that. So again, Sylvian fissures or lateral sulcus. Then slightly more posterior to the level of the choroid plexus. So you got your lateral ventricles here, choroid plexus, interhemispheric fissure. a piece of the corpus callosum, and finally, all the way posterior. So here you got your interhemispheric fissure, occipital lobe, and periventricular white matter. So those are the coronal views. Next are the sagittal views. So the way we scan, we usually begin sagittal midline, then go to the right, and then go to the left. Also 6 images, kind of duplicating the midline when you come back from the right. Now, some places, some people will start in the right and they'll sweep all the way through. Every place is a little bit different, but you want to get these images. So beginning sagittal midline, again, you have the corpus callosum right here, thalamic adhesion, 3rd ventricle, cerebellar vermis, 4th ventricle, and here's with the labeling. Corpus callosum, again, rostrum, genu, body, and splenium, CSP, cavum vergi. Here is the cerebral aqueduct, or aqueduct of Sylvius. This part here is known as a fornix. This is with a linear transducer. Again, you got the corpus callosum, the echogenic fornix right here above the thalamus. And then you can also see the pons, the medulla oblongata, midbrain, and brainstem. Sometimes it's very hard to make out these structures in bigger babies. In more premature neonates, you can definitely see it. Here you got the cerebellum again and the 4th ventricle, always triangular shaped. So then you begin parasagittal to the right, parasagittal to the left. So your first stop is the caudate nucleus or caudothalamic groove, which we saw this image earlier. Focus on this part for bleeds. Then you got the lateral ventricle, again, anterior horn, body, occipital horn, and temporal horn with chori plexus. This is a good part. Sometimes blood collects here. That's another good part to view. And then all the way lateral, you're going to get the periventricular white matter, the Sylvian fissure or lateral sulcus in parasagittal, separating the frontal occipital lobes to the temporal lobes. And here's the view of the extra-axial space again. You see there's some fluid here, which is normal. This is the superior sagittal sinus. And you can see there's like little echogenic lines here. Those are vessels. Those are perforating vessels in the arachnoid matter. And that's normal. So again, it would be dura matter, arachnoid space, and then pia matter on the brain. So another view is the posterior fontanelle. And that's where I said earlier, you can use that view. If there's any blood collecting in the occipital horn, you might not be able to see it from the anterior fontanelle. This is a good view to check there. Here you got 2 views, chori plexus, lateral ventricle, and the occipital horn right here. Then you have the temporal window, which is going to give you a biparietal diameter type view, like the one you would get in a fetus. Obviously, whatever you're approaching from is the side that's closest to the face of the transducer. So this is the baby's left side. So this would be the left side of the head. But obviously on this exam, this is right temporal. So I usually approach from the right temporal unless the baby has some dressings or something like that. So you can see the Sylvian fissures right here, the lateral sulcus. Here you got the CSP, lateral ventricles, interhemispheric fissure, a little bit of the cerebellum, and midbrain. And you got a little bit of 3rd ventricle as well. Then you have the mastoid view. This is good for looking at the cerebellum and posterior fossa. So if you have any posterior fossa cyst or cerebellar hemorrhages or anything like that, this is a good view. And here's the gross anatomy view of the cerebellum. You see the 4th ventricle right there. 4th ventricle, cerebellar vermis right in the middle. Very nice view. Lastly, we'll do a basic overview of the vascular anatomy. So this is through that same temporal window. You're going to get the circle of Willis. This is in an infant, and you got the middle cerebral artery, anterior cerebral arteries on both sides, and the posterior cerebral arteries, which is usually subdivided into segments P1 and P2. So circle of Willis, and the blood flow or the arterial velocity in these arteries usually go highest from MCA to PCA. So MCA, then ACA, then PCA in velocity, ascending to descending. The normal resistive index is greater than 0.6, which is important because in patients that have hypoxia or hypoxic-ischemic encephalopathy, they'll normally have lower resistive indices due to brain sparing effects. So they're going to be receiving a lot more blood flow. So that's an indicator of hypoxia. And here's a transverse view with the circle of Willis again, middle cerebral arteries right there, posterior cerebral arteries, basilar artery, and then the 2 vertebral arteries. So here we have sagittal midline and coronal. So this is very nice. You can see the internal carotid artery. You can almost see maybe the ophthalmic artery coming off of there. Then that goes, the ICA goes up into the brain, bifurcates into ACA and MCA. So in sagittal midline, you see the ACA, which then goes on to become the pericallosal artery. So here your corpus callosum, pericallosal artery. Then you have your internal cerebral vein and your vein of Galen. So vein of Galen, very important also for aneurysms. And then you got the straight sinus. And here you have coronal, again, circle of Willis, middle cerebral arteries, anterior cerebral arteries, and the terminal internal carotid arteries. In that view, if you angle posteriorly, you'll be able to see the basilar artery going into the circle of Willis. So that pretty much concludes the anatomical and technical aspect of this talk. Welcome to the second portion of this video. We're going to go over neonatal neuropathology. So the number one reason to do neonatal brain ultrasounds is hemorrhage, particularly interventricular or intraventricular hemorrhage. Now, 45% of extreme premature infants, so that's infants below 28 weeks or under 1,000 grams, develop intraventricular hemorrhages. It is thought to be caused from impaired autoregulation. So these patients, they have these germinal matrices that are very delicate. Any change in pressure or blood volume can cause those little capillaries and blood vessels to rupture, leading to hemorrhage. 50% of bleeds usually happen on the first day. And by the fourth day, 90% of all bleeds that are going to happen have already happened. So the prevalence of intraventricular hemorrhage by grade is grade 1, 17%, grade 2, 12%, grade 3, 3%, and grade 4, 3 or 3.8%. Now, obviously, the lower the grade, the better it is for the baby, and the more common it is. So this prevalence is of all bleeds. All right, so risk factors are prematurity, so less than 32 weeks, especially if you're extreme premature, and less than 1,500 grams. Rapid fluctuations in blood pressure or blood volume. Transfer from outside facilities has been known to correlate with increased risk of hemorrhages. Any type of coagulopathy or blood clotting disorders, respiratory distress, and hypoxic-ischemic events. Now, the grading system of bleeds consists of 4 grades. Grade 1 through grade 4, grade 1 being the less severe, and grade 4 being the most severe. Grade 1 through grade 3 are thought to begin in the subependymal region and then break into the ventricles, whereas grade 4 is thought to be from venous infarction in the parenchyma itself. So we're going to go over them all. This is a quick overview. So this is a normal brain. This is not to be confused with blood. This is the choroid plexus and the roof of the third ventricle. Then you have a grade 1, which is just containing blood within the germinal matrix or the subependymal region. You see this side, there's 2 bleeds, and here's the corresponding image. And then here's a grade 2. So the bleed's a little larger, it's broken into the ventricle, it's taking up less than 50% of the ventricular space, and there is no ventricular dilatation or ventriculomegaly. So grade 3 is also a intraventricular hemorrhage with greater than 50% of the ventricle being taken up by blood and or ventriculomegaly. And then grade 4, which is an intraparenchymal or periventricular hemorrhage, is just blood within the parenchyma. So grade 1, here's a gross anatomy view or gross pathology view. You see the blood right here. This is the lateral ventricles, septum pellucidum. So it is limited to the subependymal or germinal matrix region. It's usually less than a centimeter. If no progression, the outcome of this condition is as if they never had a bleed. So grade 1s usually have pretty good outcomes, pretty good prognosis. 80% of grade 1s can progress into higher grades. So here's that same image, bilateral, grade 1. And it's good to see it in coronal and sagittal. Earlier I mentioned that the choroid plexus begins about 1/3 or halfway to the thalamus. So this is choroid plexus, and this is in grade 1 bleed. You can see that gogenicity is very similar. Here's another example of a left-sided grade 1 bleed. So here's your thalamus, caudate nucleus, and you can see this little groove right here. That's where the blood is. And it's right there. Sometimes it's a little harder to see in coronal and easier to see in sagittal. So this was a 31-week premature infant, measuring about 1,500 grams. Over time, the bleeds can involute and undergo cystic degeneration. So if they don't progress to grade 2 or grade 3, they just stay there, and eventually the blood clot starts to retract, and you have these little cystic spaces, and that's just cystic degeneration. Over time, there may be a subependymal cyst that's left over in its place. In fact, sometimes when you scan infants, you'll notice a subependymal cyst, which is different from a choroplexus cyst, and that could be maybe that the baby had, or the fetus had, a bleed or grade 1 in utero that just has resolved, and what's left over is a subependymal cyst. All right, so grade 2, once the blood has gone from the germinal matrix and broken into the ventricle, you have a grade 2. So you're not going to have ventriculomegaly, so the ventricles are not going to be very large. They're going to be normal sized. And the blood can make a cast of the portion of the ventricle that it's in. As you can kind of see right here, the blood is taking up some space here. And this is a grade 2. Right there, it's within the ventricle. And you can see here, it's taking up a good portion of the ventricle. But the ventricles are not enlarged. This is that same patient. The initial exam, you can see the blood within the ventricle without ventricular dilatation. And then you can see the blood clot involuting and retracting over a period of 2 weeks and undergoing cystic degeneration as well. And then finally, 2 months later, all that was left was this calcified plaque here attached to the choroplexus. No ventriculomegaly. The ventricles are very small, slit-like, as you'd expect. Grade 3. Grade 3 is much more severe. It's going to be taking up a lot of the ventricle and also causing ventricular enlargement. So it's IVH with ventriculomegaly. The ventricular lining can become echogenic. That's considered ventriculitis. Over time, the blood products can cause irritation and cause the ventricular lining to become more echogenic and thicker. There's a 20% increase in mortality once a patient gets a grade 3. And a 35% increase in neurological deficits, things like cerebral palsy, developmental delay. So here you go. You got blood right here. Here's your thalamus. Here's your choroplexus. There's a nice chunk of blood right there. And you can see the entire ventricle is filled with echogenic material that is coagulating blood that hasn't coagulated completely yet. And there's also ventricular dilatation. And then this is that same patient 6 months later. And this patient was 34 weeks gestational age, and they weighed 1927 grams when they were born. So 6 months later, see the ventricles are kind of prominent, and there's no more blood. But there's good development of the brain. There's gyri and sulci everywhere. And then grade 4 is intraparenchymal. So a grade 4 can happen just in the parenchyma or involve the ventricles and the parenchyma. So intraparenchymal bleed, white matter venous infarct is what they believe is what causes it. Eventually, once that blood resolves, a fluid-filled cavity will be left in its place. That's a process called encephalomalacia, and the cavity that's left is usually called a porencephalic cyst. Grade 4 bleeds have a 50% chance of mortality and 90% increase in neurological deficits. So it is the most severe of all the bleeds and carries a lot of morbidity and mortality. Here's you can tell 27 weeks gestational age, so extreme preemie. You can see there's no sulci or gyri, pretty much, immature brain. You can see this large amount of blood within the parenchyma. There's also blood within the ventricle, and there's midline shift. So the midline is being shifted to the left. That's caused from increased pressure, which causes further cerebral tissue damage. So here you can see the blood within the parenchyma and then blood within the ventricle. Here's another one on the opposite side. So you got all this blood here in the parenchyma. Right there. Here's the periventricular white matter region. And then over time, you can see it start to undergo cystic degeneration. And there's also ventricular megaly now. This is 2 weeks after. There's blood within the ventricle as well. And then over time, once the patient's healed, 4-month interval, you can see there's a large cystic space. That's a porencephalic cyst. This cystic space usually connects to the ventricular system and is just filled with cerebrospinal fluid. Here's another one, very premature infant. You can see the SYLVIAN fissures here. Other than that, not much gyri or sulci. INTERHEMISPHERIC fissure here. And you can see day 1. day 2, and by day 3, there was a bleed. So remember earlier, usually 50% of bleeds happen on the first day. By the 3rd or 4th day, almost all the bleeds have happened. So here's the blood. On the right side, here you can see it extending from the ventricle and into the tissue. So there's blood within the ventricle and blood within the tissue. This is choroid plexus, not to be mistaken with blood. And over time, day 7 and then day 28, you can see it undergoing cystic degeneration. This one will also have a porencephalic cyst like the other case. This is a patient that presented with hypoxia. At their very first exam, their initial exam, there's no gray white matter differentiation. You can't really make out any of the structures. This is caused from edema. Over time, they developed a large parenchymal hemorrhage on the left. Right here, all this. And you can see there's also midline shift. Here's a parenchymal bleed that begins around the area of the cerebellum, in between the tentorium and the brain, or cerebrum. You see the structure right here, in transverse, and then in sagittal. And you can also see it is causing hydrocephalus or ventriculomegaly because it's obstructing the flow of cerebrospinal fluid. All right, so choroid plexus cysts, very common. They occur within the choroid plexus. They are not true cysts as they don't have an epithelial lining. They're pretty commonly seen prenatally and also in neonates. There has been some association with trisomy 18, but if no other abnormality is found on the fetal ultrasound, there's about a 1% chance that choroid plexus cyst would be associated with trisomy 18. If there's other anomalous features or other markers, there's about a 4% chance increase of association with trisomy, but still not very much. The increased risk is essentially the same whether there is a single choroid plexus cyst or multiple cysts. So if we see a choroid plexus with 2 cysts, that shouldn't raise concern for anomalies. However, up to 50% of patients with trisomy 18 have choroid plexus cyst. But that's a causation versus correlation issue. And here's a small example of a choroid plexus cyst. On the right, choroid plexus, very common. All right, so choroid plexus papilloma is a rare neuroectodermal tumor. It is a benign tumor. It does have some malignant potential, but very low malignant potential. It is most commonly seen in patients under 5 years, and is most commonly seen in infants. Presenting symptoms could be, or signs can be macrocephaly, hydrocephalus, altered mental status. It is the third most common brain tumor after teratoma, and it represents about 1% of all brain tumors, and 2 to 6% of all pediatric brain tumors. So here we have a newborn that presented with macrocephaly, and you can see here there's ventriculomegaly and this large tumor coming off of the choroid plexus, and it turned out to be a choroid plexus papilloma. So here we have your sagittal and your coronal views, and it's on the left side. It's very big, and as such, it's also causing obstruction, which leads to hydrocephalus. So hypoxic ischemic injury. It's a very important condition that happens when babies are born and they are lacking oxygen for whatever reason. They usually have Apgar scores of 0 to 3, greater than 5 minutes. They often present with seizures, coma, and or hypotonia. Associated maternal conditions are preeclampsia, fetal infections, drug and alcohol abuse, maternal drug and alcohol abuse, severe fetal anemia, cardiac disease, lung malformations, or problems with blood flow to the placenta. It is estimated prevalence of 1 to 3 per 1,000 live births. Redistribution of blood to the brain may lead to multi-organ failure. Initially, the sonograms look normal, but it's important to look and Doppler the cerebral arteries, the anterior cerebral artery and the middle cerebral artery, and look for the resistive indices. If they are equal or less than 0.55 in the first 72 hours, that indicates hypoxic ischemic injury of the brain. Sometimes you can also see echogenic lesions within the basal ganglia, like the thalamus or the cauda nucleus, but you might need to use a linear transducer to see those. Oftentimes I've done patients that have hypoxic ischemic injuries, and the brain looks normal with the curved probe or the microcurved probe, and you use the linear and it shows some echogenic lesions within the basal ganglia. You can also develop little echogenic lesions and the periventricular white matter too. These are usually due to infarcts, and they definitely present after if they are going to be there. All right, so this was a newborn with cardiac arrest, and you can see that the initial Dopplers were of low resistive indices. And eventually the baby went on to have brain death and those reversal of flow in the cerebral arteries. And you can see the edema in the Sylvian fissure. Now, when you're Dopplering the cerebral arteries, it's important to know the patient's cardiac status, because if they have a patent ductus arteriosus, that might change the waveform and cause some reversal of flow in some cases. But this one, they obviously had good diastolic flow with low resistive indices, which is usually due to brain sparing effect. And then they developed reversal of flow, which means that the capillary beds of the brain are closed. Here's a 32-week gestational age baby who had a biophysical profile, low score biophysical profile, and then had a cardiac arrest at birth. And here you see the echogenic lesions around the ventricles. The ventricles are prominent, and then they became very enlarged. And you see how those echogenic lesions eventually start to become cystic. Those are infarcts. Here's another baby who had hypoxia at birth. And you see again, there's no differentiation between the gray and white matter. The brain looks smudgy. That's a sign of edema. And then 3 months later, you see just how much brain damage there was. There's cystic encephalomalacia all over the brain, increased subdural fluid, increased fluid in the tentorium, just a lot of cerebral damage. All right, on to periventricular leukomalacia, or PVL. A PVL is a white matter disease, usually caused from white matter infarctions. The periventricular white matter is normally echogenic, as you can see here. It's less echogenic than the choroid plexus, and this is also called the periventricular blush. Now, early on in the stages of periventricular leukomalacia, it can be a little hard to tell. Obviously, the more premature the infant is, the higher risk they got. And that's why we do serial ultrasounds. If it's expected, if the echogenicity of the periventricular white matter is a little increased, they can do serial ultrasounds to see if they do eventually end up developing cystic spaces within the periventricular white matter, which would be PVL. Typically, cystic changes appear about 2 to 6 weeks after the vascular insult. And these patients also have significant neuromotor impairments. Here you have a patient whose initial exam looked much like the other ones. Very smudgy brain. Echogenic sulci. Then brain stayed looking edematous with ventricular enlargement. And then eventually they developed periventricular leukomalacia 2 months later. You see all these cystic spaces. Here's another one. 25-week gestational age, 720 grams, extremely premature. The initial exams were normal. Periventricular white matter looked pretty decent. And the serial exams immediately started to get some echogenicity, increased echogenicity in the periventricular white matter, which ended up developing into cystic spaces, which is PVL, or periventricular leukomalacia. So you see how here's normal and parasagittal. Then you start to have all these little echogenic spaces, which then become cystic spaces. All right, hydrocephalus. Hydrocephalus is pretty common. It is an abnormal accumulation of cerebrospinal fluid in the ventricles with ventriculomegaly, so the ventricles get enlarged. There are 4 types: communicating, non-communicating, ex vacuo, and normal pressure. Depending on the severity, they may require a VP shunt or a reservoir to be placed in to reduce that ventriculomegaly, which then puts pressure on the brain, which can lead to brain damage. Another cause of hydrocephalus is post-hemorrhagic hydrocephalus, and it results from mechanical obstruction by blood within the lower parts of the ventricular system. The trigone and the occipital horn are the first to dilate. The incidence in surviving infants, that's infants that have had IVH, is estimated to be around 15%. So around 15% of babies who develop intraventricular hemorrhage go on to develop post-hemorrhagic hydrocephalus. And 10 to 20% of those patients require a ventriculoperitoneal shunt or a reservoir to reduce that fluid. Here we got a case of very large ventricles, so ventriculomegaly, and this is important why we need to, get these hydrocephalus cases treated because the increased the increased pressure on the brain can lead to cystic encephalomalacia as well. So here you see you got very large ventricles, and the parenchyma of the brain is very cystic. So lots of white matter disease. Here's another case of hydrocephalus, very large ventricles. You can see how thin the parenchyma is. This is in transverse. You can see the choroid plexus. Oftentimes, depending on the position of the head, you can see the choroid plexus actually dangling. And here's the same patient with a reservoir. So we went over the extra-axial spaces real quickly in the other video, but it's good to know, again, we also observe and monitor the extra-axial spaces for increased fluid or blood. This is with a 24 megahertz transducer off the new GE Logic E10, and you can see the skin. This is a cranium here. Cranium here, from here to here is the anterior fontanelle. This is superior sagittal sinus, and this is the arachnoid space. So arachnoid space, and then pia mater, and then the dura. So if you had fluid above this, it would be subdural. But since there's fluid below this, is within the arachnoid space, it's normal. And that is a tiny amount. So tiny that you can't even see it. This is with the 9L. You can't even see that fluid accumulation. But with the 24 megahertz transducer, you can see it. This is the patient we went over on the other slides. And you can see the vessels within the arachnoid mater. And then this is the dura right here. So these are normal, and these are benign enlargement of the subarachnoid spaces. This probably wouldn't even be considered that. It's usually a little bit more than that. So here we have fluid collections on both parietal lobes, right? And then with the 18 megahertz transducer, you can see the pia mater. You could also see the arachnoid space. You can see how it's echogenic, and he's got these little vessels. When you put the color Doppler, you can see the blood vessels within the arachnoid space, and then this anechoic region here. This is the subdural space. So this is subdural fluid. It's usually most likely a subdural hygroma. Sometimes if there's echogenic fluid there, it could be a subdural hematoma. And here's your superior sagittal sinus again. Here's another case with very, very large extra-axial space, compression of the brain. This is a subdural hygroma. And due to the increased intracranial pressure from this extra fluid, you can see that there's some cystic or porencephalic cyst or cystic encephalomalacia of the cerebral tissue. All right, so arachnoid cysts are fluid-filled sacs with arachnoid lining. They're more common in males to females at a 2-to-1 ratio. They're often seen prenatally, incidentally, and often they are asymptomatic. This is one of the more normal locations for them. And you can see these are prenatal images. In our place, we do, it's pediatrics, but we do women that come for fetal MRIs. We do their fetal ultrasound before they get the MRI. So this is the same patient with the MRI. So that's an arachnoid cyst. All right, so congenital anomalies, there's a very, very long list of congenital anomalies. I'm going to go over a few due to the time constraints. So beginning with agenesis of the corpus callosum, it is rare, about 1 in 4,000 individuals, and with a male to female ratio of 2-to-1. Now, you can have agenesis of the corpus callosum, which is no corpus callosum at all, it doesn't develop, or you can have a hypoplastic part of the corpus callosum. This is called dysgenesis. Usually when you have agenesis of the corpus callosum, you're going to have an enlarged third ventricle or more prominent appearing third ventricle. It happens usually between the 12th and the 16th to 20th weeks of gestation. Posteriorly, you're going to have colpocephaly, which is enlargement of the lateral ventricles in a teardrop shaped fashion. And in coronal, you're going to have a bullhorn or a moose head appearance of the anterior horns of the lateral ventricles. They look like a U, and that's because they're more separate than usual. There's also another sign called the race car sign for that separation of the lateral ventricles as well. Maternal alcohol consumption is a risk factor. So here we have a sagittal view with a normal corpus callosum. And then we have a sagittal view with the corpus callosum agenesis. So you can see there's a third ventricle and no corpus callosum. And also the gyri, they radiate, instead of going pericallosal and then lateral or horizontal, they radiate in this fashion. Here's a coronal view showing the corpus callosum right there. So interhemispheric fissure, corpus callosum. And then here you have interhemispheric fissure, no corpus callosum, dilated third ventricle. And you can see the two anterior horns of the lateral ventricles are very separated. Here's another case where the anterior portion, so the rostrum and genu of the corpus callosum, seem pretty well formed. And then the posterior aspect of it, the splenium and body, don't seem very well formed. It's very thin. And here we have an example of that same case. So you see the moose head appearance, or the race car sign. And then more posteriorly, you can see the colpocephaly, or the teardrop-shaped ventricles. And here's a side-by-side view of the ultrasound and MRI. You see a teardrop-shaped ventricles there. All right, so next up is hollow prosencephaly. It is rare. There's an incidence of 1 per 10,000 to 16,000 live births and a 0.2% incidence rate. The prosencephalon fails to develop into two hemispheres in this condition, and there's 3 types. There's lobar, semilobar, and alobar. And here you can see the continuum from normal to alobar being the most severe one. So alobar hollow prosencephaly, as said, is the most severe form. It is often associated with cyclopia. So you have one eye or two eyes fused into one socket. Proboscis, which is usually a protrusion onto the forehead or around the nose. So it is considered a monoventricle in all 3 cases. Just in alobar, it is very prominent. There's no cerebral hemispheres. There's no midline. There's no interhemispheric fissure. The thalamus is fused, and all the midline structure are also fused, and the prognosis is poor. Next up is semilobar hollow prosencephaly. It is the middle subtype. You can have agenesis or hypoplasia of the corpus callosum. You have fusion of the frontal and parietal lobes with separation of the occipital lobes. The prognosis is better than alobar. So again, you'll have thalamic fusion, and the midline structures will be fused. You do have a bit of an interhemispheric fissure, not a clearly seen corpus callosum, maybe some there in the splenium and body. All right. And you can see the anterior portion of the brain is completely fused. There's no interhemispheric fissure separating the lobes. And then the most common is lobar hollow prosencephaly. It's a less severe type. The fox is present all the way down up to the corpus callosum. You won't have a cavum septum to pellucidum. The anterior horns are fused. You can have a hypoplastic corpus callosum as well. And here's a prenatal example of lobar hollow prosencephaly. There you can see there's no septum pellucidum. The anterior horns are fused, but there is a interhemispheric fissure present, so the falx is present, and there is corpus callosum. And posteriorly, the ventricles do divide into 2 separate structures. Following up is hydranencephaly. Also rare with a 0.2% rate of incidence. It results in a vascular insult after the 12th week, usually of the internal carotid arteries. You can have a falx. Midbrain and below will be present. So you have membrane, you can have basal ganglia, you can have brainstem pons, but you're not going to have any cerebral hemispheres. You can have a falx with just an empty sac filled with cerebrospinal fluid. It is not to be mistaken with hydrocephalus or anencephaly. There are cases of hydrocephalus that are so severe that it appears that there's hydranencephaly, but even in those cases, you can see a sliver of cerebral tissue of the either right or left cerebral lobe. And in anencephaly, there is no cranium and it's just flat. There's no brain and the head is flat. The prognosis is poor and many babies are stillborn with hydranencephaly. So here we have a case, and here you can see the tentorium. And below the tentorium, you can see not very clear structure, but you can see there's midbrain structures there. And you can see there's no cerebral hemispheres at all. You can see some maybe thalamic structures there. And there is cerebellum. And here you can see the falx and just fluid. So here you can see cerebellum, pons, midbrain, 4th ventricle, but no cerebral hemispheres whatsoever. Next up is schizencephaly. Another rare condition with about 1.5 per 100,000 live births. It is a cortical malformation that creates a cleft that's lined with gray matter from the ependema to the pia mater. There's two types, open-lipped and closed-lipped. Here's a fetal view showing these areas here and this cleft-shaped area here. That's schizencephaly. Here's a postnatal ultrasound showing this area here, which is a schizencephaly. And you can see it's on the right lateral part. So here's the interhemispheric fissure, and you can see the split right here. And here's a prenatal example of hollow prosencephaly and schizencephaly. So here you can see the monoventricle, right? No hemispheres, and then all this is schizencephaly. So next up is lissencephaly-pachygyria complex. Now, lissencephaly is a neuronal migration disorder resulting in a smooth brain. So there's no gyri or sulci. Agyria would be no gyri whatsoever. Pachygyria would be broad gyri, and then lissencephaly is just a smooth brain surface. Now, when babies are born very premature, their brains almost look like they have lissencephaly, but you can see as they develop, their brain will start to create gyri and sulci. Whereas somebody who has lissencephaly, they'll be full term and their brain will look very smooth. So there's two types, which is type 1 is classic lissencephaly. It is rare, about 11.7 per million births. Presenting symptoms and signs are usually hypotonia, seizures, and microcephaly usually develops by 1 year of age. And then type 2 is cobblestone lissencephaly, which is smooth brain, but the cortical tissue has a bumpy surface, and it is associated with Walker-Warburg syndrome and muscle eye brain disease. So here's a full-term baby, 40 weeks, 2,950 grams. They have a grade 1 bleed, but if you notice, their brain is very smooth. So this is the appearance of a brain of a very premature infant, but they're 40 weeks full term and full weight. And you see there's just no gyrations or sulci. And here's another one that on first appearances might give the appearance of absent cavum septum pellucidum, which it is. There is no cavum septum pellucidum, or so maybe monoventricles, so maybe hollow prosencephaly. But as you can see here, cavum septum pellucidum agenesis. There's also some third ventricular enlargement. And from the posterior occipital view, you can see that there's a cystic structure here that connects right here. So there's Vermean hypoplasia or agenesis and a posterior fossa cyst extending outwards, which is a posterior encephalocele. And also, if you look, this is a full-term baby, you can see that the brain is very smooth. It lacks gyri and sulci. So this was a case of Walker-Warburg syndrome, which is sometimes known as heart syndrome. It is a lethal form of congenital muscular dystrophy. They typically have hydrocephalus. Neuronal migration anomalies are present, so agyria or lissencephaly, most likely cobblestone lissencephaly. They'll have a Dandy-Walker continuum. They also have retinal dysplasia, a posterior encephalocele, and cerebellar malformations. All right, so that concludes this presentation. The list of pathologies that can be found in neuroanatomy and neuropathology are very vast. I just hope I can covered a good amount of pathology, maybe some stuff that you guys haven't seen before. And again, I want to thank the ASA for inviting me to speak. It has been quite the honor. You guys can follow me on sonographictendencies.com, on Instagram, Sonographic Tendencies, Facebook, Sonographic Tendencies. If you have any questions or comments, please feel free to direct message me on Instagram. I answer all my messages, all right? Thank you so much and take care.